Hey, John.
Hey, how you doing?
I'm fine. How are you?
Hey, Rakesh, is that you?
Hello, John.
Hey, how you doing?
I'm fine, thank you. How are you?
Good. So he's all set up as far as his bandwidth is okay and everything?
Yeah, everything is fine.
Okay. You think so or you know so?
I beg your pardon?
What you know he's all set or you don't know?
I didn't get to your voice is
No,
blurring.
is he? He's got enough bandwidth, right?
Yeah, I checked his bandwidth. He was
Oh,
okay.
good.
Videos,
Oh, good.
videos all are streaming fine. It was
Oh,
nice.
very good. Okay, great.
Right. He should be here. I told him to log in 15 minutes earlier. Should be here anytime.
You know, this is being televised in China.
Yeah. Professor Zubin has a WeChat link.
Yeah, it's great.
Professor Dubovoy is here. Hello, Professor Dubovoy. Can you hear us?
Dr. Gold's coming? What's that?
Professor Dubovoy, Andrei Dubovoy from Novosibirsk, Russia. He's here.
Okay, yeah, just keep introducing people like you're doing. I mean, that's great.
Yeah.
Because you know they like to be appreciated and,
Yeah.
and introduced and respected.
May I please play one of the again the thank you videos if you don't mind?
Oh, Dr. Ben, yeah, okay, Dr. Ben's here, yeah, okay.
Yeah, we have the speaker with us.
Yeah.
Oh, the speaker's here. Hi, how you doing?
Yeah,
Hi. Hello. Is it morning in your country? Good morning or?
Yes, it is. It's
It is.
8:15.
Okay. I'm sorry. Hi.
Hi,
Professor
Raja.
Ben
Hi,
is
hi,
here.
John.
Hello,
Hi.
Professor
Hi.
Ben.
Hey,
Hi.
hey, hi
How
Ben,
are
how
you?
you doing?
Nice to meet
Hi,
you.
Milwaukee. Hi.
Yeah, hi.
Nice
Nice to
to
meet you.
see you
Thank you
again.
for sharing my presentation today. Thank you.
Yeah,
Thank you so
no problem. My pleasure.
much. Yes.
It's great. We have everybody.
Yeah.
May,
So
may
how
I
many?
please play one of the thank you videos,
Uh-huh.
John?
I'm sorry?
Can I
May
check
please?
can I
Yeah,
check
you want to practice or something? Yeah, sure.
Yeah,
can I
please,
check the
please,
videos? Okay.
please, sure, please.
Sure, no problem. Go ahead.
Yeah.
We
Can
got
you see my
15 minutes,
presentation?
so yeah,
Yeah,
it's good.
great.
Can you see my presentation?
great.
Okay. Good.
Yeah,
Okay. I'll check my video.
yeah,
So my
it's
video
playing. Yeah,
working?
yeah, it is working. Fine.
Yeah.
Okay. Great.
Do you want to make it bigger than that? Play
Okay,
it
of
when
course,
it's
of
big.
course.
Yeah, make
Of
it
course.
big. Just
Okay.
test it when it's big.
Okay.
Yeah, go ahead, play it now. Oh, good. Well,
It's looking good.
oh yeah, okay.
Is it
Good.
okay?
Yeah,
Okay,
it's
Yeah.
playing.
Great.
Yeah,
very good.
I have one video. Okay. Working?
yeah, it's fine. Working,
Okay.
working well.
Okay, great. Okay.
That's great. Thank you.
Oh, you're
Ben,
welcome.
that was a nice thing that Yuha said. Ben, did you see that? You saw that, right?
Yeah.
The best day he's had in China.
Mhm.
Yeah. Yesterday, there's more than, now it's more than 6,300 visitors.
That's
Right.
that's great.
Yesterday's
That's
Really?
great.
webinar.
Yeah, that's great. You hear? Did you hear, Professor Miyawaki?
Well, I'm going to share the screen. I'm going to show you, Ben. It's being shown now, and I'm going to get the page where it's going to be shown in China. They've already got it set up. They knew when we scheduled it.
Mhm.
Okay, I'm gonna. Okay, let me share this here. This is my chance to teach. Okay, see, they've got it all set up.
Yeah, that's great.
You see this, Ben? And this is the MedTaion page.
Yes.
And I guess they just basically straight transmit it. So,
Yes.
and they're all set up. They're all set up. So that's great.
Right.
Okay.
Right. John, may I please play one of the videos for Professor Zubin?
Yeah. Go ahead. What, you're going to play it now, or when
Yeah.
at the beginning?
Just now. Professor Bin, this is for you and all others who were the speakers in the month of June.
Oh, sure. Oh, great. That's great. Yeah. We'll play it at the beginning, okay? So,
Yeah,
so it's recorded, okay?
Yeah, it's
Raja?
recorded. Yeah, I can hear you.
No, when I introduce you, when you start, you can go into this right away, or do you want to do that at the end?
Yeah, we'll do that.
You want to do it at the end of the video of the web chat? Yeah, let's do it at the end rather than the beginning, okay?
Okay.
Yeah, we can do it at the end, and we'll leave it in the video. It'll be part of the video. Yeah, that's great. Okay, we got 8 minutes.
Yeah, very good. We have another 8 minutes.
Yeah.
Hello, Liu is here. Hi, Liu.
Hi, Raja.
Yeah, hi,
Hello,
Liu.
Prof.
How are you?
Hello, Professor Zubi.
Hi, Dr. Liu.
Professor Miyawaki, this is our co-host for today, Professor Liu Boon Sang is from Malaysia and he's an active part of ACNS. Liu,
Hello,
this
Prof.
is our speaker.
Yeah, nice meeting you here, Prof.
Sorry, it was mute. I'm sorry. Nice to meet you. Satoru Miyawaki from Japan. Thank
You
you
know,
for the
there's a,
invitation.
excuse me, there's, can you change your light? Yeah, there's your part of your face is very bright. You know what I mean?
No.
Yeah.
I know. Okay,
let's,
wait.
Can we
Okay, wait.
play with that? Can we play with that a little bit? Play with the light. You may just need to move the light. Yeah, that's better. That's better. That's better. Much better.
Too dark?
Yeah, that's better. Better.
Okay, thank you.
Better.
I'm sorry.
That's much better.
Okay.
Who else is
John,
there?
your face is not appearing, John.
No, not yet. Not yet. I got to do some stuff.
Okay.
I'm just doing a little last minute work. Last minute blast.
Yeah, now it looks great. Itichai is here, our very good friend Itichai. Hello, Itichai. Are you there? Itichai. Itichai is from Thailand. Professor Duboy, are you here, Professor?
So I'll
Professor
just introduce you,
Duboy.
Roger, and that's it, right?
Yeah, we have 5 more minutes. So.
Yeah. I'll just count down and you take over after I come to 0.
And straight go into the presentation then.
So John, you are very busy.
Yeah, John is a very busy man.
Yeah.
I tell you, but what a boost you gave there to introduce us to the Chinese community. I mean, really. I mean, it's a great.
Yeah. Now
that's a great
neurosurgical
leap.
TV is very popular.
Yeah,
yeah.
they've been televised. I didn't know, but you know they're welcome to because it's publicly available, and anybody can take the stream and put it on their website if they want. It's added exposure. It's not competition. It's added exposure. So to a wider audience. But you know, Ben, was someone translated it into Chinese? I know that's the English one on Medtion, but someone translated it into Chinese also?
Yeah.
Yes, by myself.
Oh, you did? Oh, okay.
Yeah.
Oh, okay.
So I opened another Zoom room. So when I speak Chinese, I will mute in this
Oh,
platform.
okay. Can you send the link send me the link when you get a chance?
No. That's a link. You already get it.
I'm sorry?
You already show me the link. It's the
Oh,
same
okay.
one.
Oh, okay. The Medtion.
Yeah.
Oh, okay.
Yeah.
Okay, I'll look at that. We have another webcast in China tomorrow. I think I have a minute here. I can show you. I think I showed it to you. Let me get it here. I'll try to show it during the webcast also. I think I showed it to you already, Dr. Vin. Did I show it to you yesterday, I think?
Yeah, Mike should. Yeah.
Yeah. Do you know the name? Yeah, he does a lot of minimally invasive glioma surgery. He's working with Charlie Teo in Australia.
Yeah.
So we have 3 minutes. Algeria, welcome Algeria. Yeah, a lot of people like to keep quiet.
Yeah.
They're welcome. They're welcome, but they just kind of want to stay in the back, which is fine. It's a new technology. How you doing, Sarik?
Fine.
Welcome back. You're a regular.
Regularly, yes.
Well, welcome.
Thank you.
Yeah, and all you guys can participate when it starts. You know, you can participate. You know, it's for. That's what it's for.
Yeah. My friend Itichai is here. Hello, Itichai. Are you there? Yeah, hi, man.
Yeah.
How are you?
Hi, everyone. I'm very fine.
Welcome.
I'm fine, thank you.
It's a long time. Yes.
Yeah. How's the kid?
Yes.
How's your kid? Is he okay?
He's
Doing
very
great.
good now. Yeah, because yeah, we are very safe in Thailand now from COVID infection. Yes.
Right. So nice to see you. Thanks for coming.
Yeah, nice to see you. Thank you for organizing session about this lecture. Thank you.
Welcome. Welcome anytime, dear.
Yes.
There are participants from Kazakhstan as well. Dusanbe, Professor Dusanbe from Kazakhstan. That's great. Welcome.
Okay, Roger,
Yeah.
I'm just going to count down, and after I get to 0, you just take it, okay?
Yeah, sure.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Hello and welcome, friends. Today is the 3rd resident webinar of the ACNS, and we have a great speaker today about a very rare disease, that is Moya disease. And let me introduce to you Professor Satoru Miyake from Tokyo University, Japan. He's going to talk about the topic I said earlier, Moya disease. Professor Satoru Miyake, on behalf of the ACNS Education Committee, and Professor Yoko Kato, I sincerely welcome you to this platform of ACNS webinars. To chair this session, we are fortunate to have here with us Professor Zubin from Shanghai Fudan University. We are so blessed with the everlasting support from Professor Zubin for this educational ventures of the ACNS. Professor Zubin, on behalf of the Education Committee and Professor Yoko Kato, I hereby welcome you, sir, to this platform. Professor Zubin holds the largest number of bypass in this world for Moya disease. So we are so blessed to have his presence to chair this session of Satoru Miyake, Professor. So, Professor, you may please start your presentation.
Okay, thank you. Yeah. Thank you for the introduction. I'm Satoru Miyawaki from the University of Tokyo. So can you see my presentation?
Yes.
Okay. It's my great honor to be here to make presentation at this webinar resident webinar. So today I'll talk about Moya disease and mainly about surgical treatment, and I also do some research on genetic analysis Moya disease. So I will mention about my research too. Okay. So sorry. I'll start with a little bit of my self-introduction. I'm from Department of Neurosurgery of the University of Tokyo. This is my hospital, and this is a member of my department. It's about 30 to 40 neurosurgeons at my department. I graduated from the University of Tokyo in 2003, and I started residency in 2003 and finished at 2009 and passed the Japanese Neurosurgical Board. After that, I entered the graduate school and I did some research on Moya disease, genetic analysis of Moya disease, and I got the PhD in 2014. After that, I started working at the University of Tokyo Hospital, and I also study abroad in Montreal, in Canada, in 2018. And I did the clinical work and also genetic analysis research at there. So my clinical specialty is cerebral vascular surgery, including Moya disease. I also do cerebral aneurysm, cardiac stenosis, cavernous angiomas, and arteriovenous malformation surgery. And I also do benign tumor surgery, including skull-based surgery, meningioma, and schwannomas. So this is my research projects. I'm interested in human genetics. I do research on Moya disease, also cerebral cavernous malformation and neurofibromatosis too. Now I also do benign brain tumor research, mainly genetic analysis of meningiomas and schwannomas. And I'm also interested in brain ischemia research. Today I'll talk about, now I'll start my presentation about the surgical strategy for Moya disease. Okay, the main pathological condition of Moya disease is bilateral chronic progressive stenosis of internal carotid artery at its terminal portion. It is also characterized by the abnormal vascular network called Moya disease, Moya vessels, which means puff of smoke in Japanese as collateral circulation. Revascularization surgery is indicated for symptomatic cases, mainly ischemic onset. And recently, there are many evidences for hemorrhagic onset case. It is well known that bypass surgery can be effective in ischemic onset cases, preventing future stroke events in adults with Moya disease. Recently, randomized trial from Japan called Japan Adult Moya Trials. We call it JAM trial. This trial proved that bypass surgery can be effective in hemorrhagic cases for preventing future stroke events. Moreover, the JAM trial showed that posterior hemorrhage are at high risk for rebleeding and occur greater benefit from surgery. I'll present our surgical strategy for Moya disease in clinical outcomes. And I'll also present the result of the analysis of the revascularization pattern of the surgery. So, purpose of our protocol is to make extensive revascularization to the frontal lobe. For patients over 10 years old, we perform STA-MCA bypass and encephalomyocyaninosis, which is indirect bypass. So we perform combined surgery for patients over 10 years old. For patients under 9 years old, we perform EDAS plus EMS, which means indirect bypass. But in some cases, we also perform STA-MCA bypass in EMS. This is the clinical characteristics of the 60 patients we treated between 1996 to 2014. We treated 29 pediatric cases, 48 hemispheres, and 36 adult cases and 43 hemispheres. Most of the cases were ischemic cases. However, recently we are performing more and more hemorrhagic onset cases based on the evidence of a JAM trial. I'll show you some videos of my surgery. This is a case of ischemic onset 35 years old male case. Sorry. Okay. So we make the skin incision like this. We make a skin incision about the parietal branch of the STA. We use temporal muscle for EMS. We preserve middle meningeal artery. We cut the dura like this. We first prepare the recipient, and we prepare donor, the STA parietal branch. We cut the, we make the fish mouth cut. After clamping the recipient, we first do the stay suture. We make the stay suture. We make the intermittent suture side by side. We make about 5 sutures on one side. And after the clamping, we do the ICG video angiography to see good flow from the STA. This is EMS. We put the temporal muscle under the bone flap, and we finish the surgery. We can see good bypass flow in the MRI. This is a case of ischemic onset 8-year-old female case. And this we perform EDAS plus EMS, which is indirect bypass. So it is the same skin incision. We make the skin incision above the STA parietal branch. We use temporal muscle for EMS. So we make the bone flap. We preserve MMA, which could be revascularized from the MMA. So we suture this STA to the dura, and we perform, this is EMS. We suture muscle to the dura, and we put the bone flap and finish the surgery. This is EDAS and EMS. Next, I'll show you a case of a hemorrhagic case. This is a 50-year-old female which presented with right thalamic hemorrhage. This case had a choroidal anastomosis, which is an anastomosis between choroidal artery and medial end of the medullary artery. Choroidal anastomosis is known for high risk for hemorrhage. I'll show you the video. So the same skin incision, we make the skin incision above the STA parietal branch. We also prepare frontal branch. We make the bone flap like this. We preserve MMAs. We use a video, ICG video angiography to select the recipient. I chose to use this artery. This is prefrontal artery. We put Zerholms under the recipient to make anastomosis easier. We cut the fish mouth cut. Same as the previous case, I first make the stay suture. After clamping the recipient, make the arteriotomy and remove the clots from the interlumen of the recipient. I make the STA suture first. And then I make the intermittent suture side by side. I use tin zero nylon for suture. And then once I finish the one side, I move on to the other side. After finishing the suture, I declamp the recipient. There are some leaks, but it will stop afterwards shortly. Declamping the STA, we could see the good flow from the bypass. We also check by the Doppler. This is the final view, good flow from the bypass. This is EMS, the indirect bypass. In more and more cases, this indirect bypass is very effective. I'll show you the result of the revascularization pattern afterwards. This is after operative CT. This is MRI. We could see good bypass. So this is surgical complication within 30 days after surgery. We had some infarction and also infection, but totally the outcomes are good. And this is long-term post-surgical result. Most of the patients improved the symptoms. And totally, I believe these results were good. So I move on to the analysis of the revascularization pattern. So we have been evaluating the revascularization pattern to answer to the question, which surgery is more effective, direct bypass or indirect bypass? To answer this question, firstly, we score the table for donor artery, which artery is most dominant in the after post-operative angiogram performed about 6 months or 1 year after the surgery. In this case, deep temporal artery, which means artery from the EMS, from the muscle, is dominant. And the STA, it's not that effective. And it's also there's a revascularization from the MMA. So in this pattern, deep temporal artery, which means EMS, is the most dominant, show the most dominant revascularization. So I characterize the revascularization pattern into these 4 patterns. This pattern, STA, which means the direct bypass, is most dominant. In this pattern, STA and deep temporal artery, which means the direct bypass and indirect bypass, almost equal. In this pattern, deep temporal artery, which means EMS, the indirect bypass, was most dominant. And this pattern, there was no revascularization. So this is the result of the revascularization pattern with surgery with STA-MCA bypass in EMS. So in adults, total 25 hemispheres. Pattern 1, which the direct bypass was dominant. There was 7 cases, 28%. And pattern 2, STN and EMS was almost equal. There was 36%. And pattern 3, which means indirect bypass, EMS was dominant. There was 32%. In children cases, there was no cases with pattern 1, which means STA, direct bypass dominant. Pattern 2, 33%, and pattern 3, 67%. So from this result, EMS is very important in surgery with STA-MCA bypass in EMS. So EMS was effective bypass both in adults and children in surgery with STA-MCA bypass in EMS. So this is the result of the revascularization pattern of cases with EDAS in EMS. In adults, pattern 2 and pattern 3 were 50%. And in children cases, pattern 2, 46.2%, and pattern 3, 50%. So in surgery with EDAS in EMS, EMS was effective bypass in this surgical procedure too. So the advantage of EMS is less technically demanding and obviating the needs for temporary occlusion of vessels. And it's also promoting gradual development of revascularization only where the brain needs it. So we believe in Moya disease revascularization, EMS is a key component of the surgical treatment of Moya disease. It can adaptable revascularization is developed to meet the demand of blood supply in the ischemic area. This is our result of the, this is our paper presenting these results. So the surgical procedure applied under the total protocol shows clear efficacy of revascularization. Our analysis of donor arteries for revascularization indicated that deep temporal arteries via EMS have a pivotal role in the successful revascularization. So I will move on to the genetic aspects of Moya disease. Moya disease is known for the high prevalence of East Asian population. And it is also known for the high incidence of familial onset. So existence of genetic factor for Moya disease has long been suspected. But exact gene had not been identified. Recently, a gene called RNF213 was identified as susceptibility gene for Moya disease. This is a group from Tokyo, from Japan, Tohoku University, and this is a report from Japan, Kyoto University, both reported in 2011. So this group performed a genome-wide association study for 72 cases of Moya disease and 45 cases. And they identified a strong association in the SNPs in this area. And they identified a gene called RNF213 in this area. This is a report from the Kyoto University in Japan. They performed a whole exome sequence for 8 patients from different familial pedigrees. And they identified RNF213 missense mutation in a gene called RNF213 for the only common variant among the 8 pedigrees. So summarizing the result of the 2 studies, nearly 80% of Moya disease patients have the same single nucleotide variant, this variant in RNF213. RNF213 is a big gene, and the exact function is not is unknown yet. So we performed this RNF213 variant genetic analysis of RNF213 variant in all cases. We did a Sanger sequence. This shows the wild type, and this shows the heterozygote variant, and this shows the homozygote variant. We analyzed 126 Moya disease patients. 78.5% of the Moya disease patients had the variant. In control, there was also 2% of the control which had this variant. but there was a statistically significant association with Moya disease. So I moved on to the next analysis. So we have proved that there is a big significant association, this hotspot variant with Moya disease. So we figured, are there any other variant associated with Moya disease in the RNF213? RNF213 has 69 exons. It's a big gene. So we use next generation sequencing to analyze the entire RNF213. We analyzed 85 Moya disease patients. We firstly analyzed performed the association study. Afterwards, we focused on the rare variants, and we we checked with the rare variants in the previous report, compared the variants in the previous reports. So this is the result. We found 60 missense variants, and we figured that there are some susceptibility variants in this missense variant. The result of the association study, the hotspot variant was the only significant association with Moya disease. So rare variants in Moya disease in the previous report, there are 11 reports about RNF213 rare variants previously. This is a summary of the rare variants reported in the previous reports. There were 117 variants. The variants above are found in the Asian population, and the variants below is the variant found in the non-Asian variant, for instance, Caucasian, European populations. You can see that the variants are mostly found in the C terminus of the RNF213 around the ring domain. So the function around this domain is important for the pathogenesis of Moya disease. The hotspot variant is positioned here. In our cohort, we found this variant, which was already reported in the previous report. So we figure that we assume that this variant could be Moya disease associated variant. But a replication study for larger cohort is necessary, and furthermore, elucidation of the biological effect of the variant against the intracranial artery stenosis is necessary. So 18 cases in our cohort did not have the hotspot variant nor any other rare variant. So whole genome-wide sequence is necessary. To determine the causative variant, larger cohort or many familiar cases are needed. So summary, RNF213, this hotspot variant is significantly associated with Moya disease. So I will show you some illustrative cases. This is a case of twins. Both had the same variant, and this patient's daughter had the variant, and these patients all occurred Moya disease. But interestingly, the founder of this pedigree, this grandfather, did not show any stenosis, even though he had the variant. So not all the patients who have the variant grow Moya disease. This is an interesting case. This is a 72-year-old male, had the baseline disease, hypertension, ischemic heart disease, and smoker, which are diagnoses. So we diagnosed this patient as atherosclerosis. But afterwards, her nephew, a niece, presented with unilateral Moya disease. Because she was relatively young and did not have any baseline disease, we figured this patient was unilateral Moya disease. And afterwards, we performed the genetic analysis, and both these patients had the variant. So what we think from this case, it is sometimes difficult to distinguish Moya disease from intracranial atherosclerosis, especially in the elderly patients. Moya disease is a rare disease, idiopathic. Intracranial stenosis is common disease and mainly thought as atherosclerosis. So the hypothesis is that we assume that this hotspot variant, RNF213 hotspot variant, could be associated with a wide spectrum of phenotypes of intracranial artery, major artery stenosis, including Moya disease. So we did association study of this RNF213 hotspot variant with intracranial artery stenosis, not diagnosis as Moya disease. We analyzed 1,000 subjects, 126 Moya disease patients, unilateral Moya disease patients, and this is the patient we are focusing on, 447 intracranial artery stenosis, not diagnosed as Moya disease. We also analyzed extracranial artery stenosis, cerebral aneurysm, and intracranial hemorrhage, and controls. So this is the result of the analysis. So Moya disease, 78%, and unilateral Moya disease, 70% had the variant. So not only with definite Moya disease, this variant also had association with unilateral Moya disease. But extracranial artery stenosis, cerebral aneurysm, intracranial hemorrhage, and control, they only had around 2%. So there was no association with these diseases. For intracranial artery stenosis, there was 20% of the patients had this variant. So the p-value was relatively low. This hotspot variant had significant association also with non-Moya disease, intracranial artery stenosis. So these are the MRAs of intracranial artery stenosis patients with RNF213 variant. These patients are relatively old, and they had risk factors for atherosclerosis such as hypertension, diabetes, and smoking. So these patients are clinically diagnosed as atherosclerosis, not as Moya disease. So this is a schema of the result of my study. 80% of the Moya disease have the hotspot variant, and also about 70% of the patient had the unilateral Moya disease had the hotspot variant. Moreover, 20% of the non-Moya disease intracranial artery stenosis have the hotspot variant. So the variant is associated with wide spectrum of intracranial artery stenosis, including Moya disease. Moya disease could be just one of the phenotype of the wide spectrum of disease caused by RNF213 variant. And this hotspot variant is present in 2% of East Asian population. On the other hand, very rare in other population, including European population. So this RNF213 variant would be the one genetic factor which explains the regional difference in Moya disease and intracranial artery stenosis, which is known to be prevalent in Asian population. I published several papers. These papers were published in Stroke, and paper was published in Journal Stroke and Cerebrovascular Disease. So this is the unsolved issue. So RNF213 hotspot variant exists in nearly 2% of the East Asian population. And not all the people with RNF213 hotspot variant develop Moya disease or intracranial stenosis. So hypothesis is that there could be a determinant factor for development of Moya disease. So this the next my task for my research is to identify this factor. If I could identify the factor, which could be the determinant factor, we can predict the onset of Moya disease. So I'm sorry a little bit earlier to finish. This is my conclusion. Encephalomyocyaninosis is a key component of the surgical treatment of Moya disease. And genetic factor RNF213 variant is associated with Moya disease and intracranial artery stenosis. It could be a genetic risk factor for ischemic stroke. Thank you. Thank you for listening. And please visit Japan.
Thank you.
This is all. Hey, this is all. Finish my presentation.
It was an exciting presentation, bringing new insights into the genetics of the Moya disease as well as surgical treatment. Professor Zubin, you may please comment, Professor Zubin.
A very nice presentation. Actually, I'm very familiar with this content because I already discussed this genetic aspect with Miyawaki for 3 years at least. But, you know, in Chinese, Chinese genetic research, it's a little bit different with Japanese because
I know.
Yeah, because you know it's female predominant in Japan. It's around 2.8 to 1. But in China, it's almost 1 to 1 for male and female. Yeah. And the genetic aspect is almost a little bit different.
Yes, it's a very interesting point. I know the RNF213 variant is not that common in Moya disease in China. Chinese.
But I agree with your conclusion that there may be some factor X which is decide the Moya or some intracranial stenosis. Yeah.
Okay. Thank you, Professor Bin, for those comments. One of the questions I would like to put forward to Professor Bin as well as Professor Miyawaki is the rarer forms of indirect vascularization. That one of the methods was pile synangiosis described by Michael Scott, which appeared in JNS Pediatrics in 2004. And they opened the arachnoid and they suture the vessel to the pia of the brain. And they have shown that it had nearly 143 patients were taken in that study, and almost in most of them the stroke was prevented. So do you have any experience for pile synangiosis? We can't hear you, Professor. Hello?
The mic is muted.
Yeah, unmute, please.
Miyawaki, you should.
I'm sorry, muted. It was muted. So, so in our facility, we don't cut. I don't cut the arachnoids. I think it is not necessary. And even if we don't cut the arachnoid, if you put the muscle on the arachnoid, there's a good revascularization after a few months. So I think cutting arachnoids is not necessary, in my opinion. So I don't have any experience for cutting arachnoids in direct bypass.
Right. Another.
Yes, I agree with you because arachnoid membrane is not a big issue. Actually, your strategy is very similar to our hospital's
Okay,
strategy.
Okay.
Yeah, but my incision was not limited by the parietal branch of the STA.
Mhm.
So my incision of the scalp is larger than yours,
Okay, I see.
more posterior to the STA parietal branch.
Okay.
Yeah, so
I see.
it could be make the EMS even bigger.
I know.
Yeah.
So yeah, it depends because make it bigger. It's like it's more how to say. It may cause like hemorrhage or any other complication. But I think your surgery is good. But so in your opinion, it's our craniotomy is the I had to say it's sufficient. I think it doesn't show any difference even if you make it bigger. So, but we have to see which is the most efficient size for the craniotomy. What is your opinion, Dr. Bean?
Yeah, sometimes
bigger the better.
Sometimes even the occipital lobe can suffer the ischemic condition.
Okay.
So it's better if the incision was more posterior.
Okay, I see. So you change by case. You change.
Yes, change by case by case.
Okay,
yes.
that's good.
It's all individualized design.
Okay.
Yeah.
So to date, we don't change the size of the craniotomy case by case. But I think your opinion is right, and we have to think about that tailor-made craniotomy. Thank you for that opinion.
Thank you. Professor Samir Hose has a question. Samir, can you come in?
Yeah.
Dr. Samir? Samir has asked a question. Do you have any scalp necrosis or ischemia at the edge of the flap as a complication of indirect bypass?
Mm-hmm. Oh, yeah.
Do you have any scalp necrosis or ischemia at the edge of the flap as a complication of indirect bypass?
Yes, we sometimes have, but not that often. But maybe 1 or 2 cases in 100 cases, maybe we have. But okay. Yes, we.
It is well.
That's
Right. Another one.
The necrosis of the skin flap is the problem. So making the skin flap too big, I think it is a risk for the necrosis. So sufficient size of the skin flap is, I think it is very important. This is my opinion.
What is your experience, Professor Bin, in the skin flap necrosis?
I just presented in my presentation that when I don't take the cut down technique to harvest the STA.
Okay.
I always harvest the STA from inner side of the flap.
Mm-hmm.
So Dr. Liu, you visited my hospital for 1 month. Yeah, you're already very familiar for this approach.
Mm-hmm.
And when we harvested the STA, if we will close inner side circles, so after this kind of treatment, the necrosis of the flap is very rare. It's around 1 or 2 cases per 1,000 patients.
Oh, that's very rare.
Yeah.
Liu, would you like to come in? Liu?
Yeah, Prof, I just want to ask you, in your experience, especially in young patient, do you experience, a disfigurement because of the temporal muscle atrophy in long term? And then is there any other strategy we can use? For example, we just use half of the temporalis muscle, or what's any way to avoid that? Yes. Thank you, Professor.
Yeah, actually, the patient doesn't there is no deficit using the temporal muscle. I think it adapts. Opening mouth or swallowing, there's no problem. Even if he perform indirect bypass on both sides. In long term, it is okay. We haven't experienced any deficits by using the temporal muscle. That is my opinion.
Yes, I agree with Miyawaki. There's no problem after you change the position of the bone flap under the muscle.
Yeah, I think the temporal muscle can function even if he use if it's under the bone flap. I think the function, it could function as for the swallowing etc. Yeah.
Right.
Thank you,
Thank you. One of the questions from my good friend Sandeep Talari has asked that in bilateral Moya disease, what should be the time interval between surgeries on both sides?
Both sides. Okay. It depends. It depends. If it's both symptomatic, the minimum is about 3 months. I think, my opinion, about 3 months. And usually I do both. I do surgery, the next surgery after 6 months. But it depends on the symptom. If the symptoms is severe, I think we have to do the surgery earlier. But maybe minimum is 3 months. That is my opinion.
What do you say, Professor Bin? What is your strategy in bilateral?
My experience is same. Normally, I wait for 6 months because when the STA middle meningeal artery or deep temporal artery get fully developed, it need half a year. So we wait 6 months. But depends on the symptoms of the other side. Actually, you can do the other side if there's some ischemic condition happened immediately after the first side. You can do this at the same day. I have this case after this left side revascularization, the right hemisphere got the ischemic condition, so I did the other side immediately. According to Professor Stenberger's experience, because in America, the insurance only cover one time. So normally he just wait 1 week after the first operation. He did the second side because they only cover once.
That is a very good technical answer.
Yeah. It's not a technical decision. It's depends on the economic.
Yeah, definitely. Yeah. One of the interesting questions we have from Javed Ziadeh is, what if you have to do a craniotomy for the same side few years later after the synangiosis you have performed? For example, for evacuation of epidural or subdural hematoma or even a brain tumor, how can this affect the previous synangiosis? What will be the consequences for the patients?
I'm sorry,
what would happen if you have to do a craniotomy after you perform a synangiosis, maybe years later, for a brain tumor or a subdural or epidural hematoma?
Yeah. Actually, I have never experienced surgery afterwards after the indirect surgery. I once experienced a hemorrhage after the indirect bypass. At that case, we performed an endoscopic evacuation of hematoma, not the craniotomy. So I think the craniotomy after the indirect bypass surgery, it's very difficult. I have no experience for that.
Yeah, Professor Bin, do you have any experience regarding this question?
No. Actually, this is an interesting question. Just last week, I just performed meningioma resection combined with STA-MCA bypass and the EDNS at the same time, because he got the Moya disease and the meningioma at the same time. So I do that.
That is
But
very
never
interesting and rare.
never happened that the brain tumor developed in this synergiosis side.
Yeah,
Never
thank you, Professor Bin.
Not yet.
One another question from Sahli Khalili says, what do you think about the use of dead animal models to learn the anastomosis, and it may take how many times to learn? And a sequel to that question is that which is the best which is the best animal model which will be equivalent to the size of human cortical vessels? Is it chicken brachial artery or femoral artery? There are two questions.
I have no experience of using dead animal models. I use rat femoral artery to the alive rat femoral artery to do the anastomosis surgery, but mainly I use like a silicone tube for the like the exercise for the experience, and I have never used dead animal models.
Yeah, like Dr. Sachin Chimate wants to ask a question. Dr. Sachin. Sachin.
Yes, sir.
Yeah.
Yes, sir. Good evening, sir. Thank you for the excellent
thank you so much.
talk,
Thank you much.
Professor. Yes, but most of your talk was about the vast and extensive research about the genetics of Moya disease and non-Moya disease. But how does this extensive research in the genetics impact the overall management or the approach for the Moya disease? How it is important from the treatment point of view?
Actually, we have not proven the clinical importance of this genetic variant yet. We haven't. We don't know how important it is for the management of Moya disease. Recently, there was a paper from the Korean groups that showed that if the Moya disease or the intracranial patients had this variant, they had a high risk of recurrence of stroke. And this RNF230 variant could be a genetic risk factor for the recurrence of the stroke for the intracranial stenosis. But our results show that if the patient had a variant, they show milder phenotype, or the most cases were asymptomatic. And we don't know yet that how it is important for the clinical management, and this is a very important point. So this is our future task.
One of the questions asked by Professor Samir Hose is to which extent can we use MRA or CT angiogram instead of catheter angiography? So like, how is the follow-up?
Follow-up, for the follow-up or the
for the follow-up.
So
is MRA good enough?
So follow-up, I think MRA is good enough. MRA is good enough.
Professor
So
Bin,
if
how
there's
would you follow up?
any stroke or any event, I think we have to move on to the CTA or the conventional angiogram. But I think just for the follow-up, MRA is good enough. This is my opinion.
Professor Bin, how do you follow up your patients?
A follow-up after half a year, we will do the angiogram again to check the different layers of the arteries, the STA, middle major artery, and the deep temporal artery.
Right.
Yeah, and redo the SPECT.
Right.
To check the perfusion change of the side.
Yeah, one of the most interesting aspects of this surgical treatment is of omental transposition to the brain. This was first first done by Karasawa et al. In 1980, and later recently by Navarro et al. In 2012, when they did a laparoscopic omental transposition. So what do you think is how good this procedure is, and have you have any experience regarding this?
Actually, I have no experience, but I think using momentum, I think it's too, invasive. I think just
They have
using
done
it.
it laparoscopically, laparoscopic
Yeah,
harvesting
I
by
know, but
Navarro et al. From the
so
Stanford Hospital.
like if the STA and MC, the temporal muscle is not effective, I think we could use it could be one option. But to my opinion, STA and using temporal muscle is good enough. We can even use like occipital arteries, but I think using momentum it's too invasive. Even though using laparoscopic, I think it's too invasive for Moya disease.
Yeah, I never
Professor,
considered that.
Mhm.
I never consider to use that because it's too invasive and just
right,
they have to create a very
large
wide
tunnel.
tunnel and yeah. So
Yeah,
I won't consider it.
yeah,
No chance.
yeah. Professor,
The temporal muscle and the duro is good enough.
good enough. That's great.
Yeah.
Itichai, would you like to comment, Dr. Itichai?
Yes, thank you. I would like to ask Professor Satoru for one question. For Moya-like disease, like intracranial stenosis, how you can select the patient to perform STA-MCA bypass in your opinion? Because in some cases it's really difficult to distinguish which one is Moya or which one is Moya like disease, and the patient have the still have the TIA. Maybe you can tell us how the criteria that you have selected to perform the surgery.
Oh yeah. So to my opinion, if it's Moya disease or it's like it's just an intracranial, even if it's Moya disease or intracranial stenosis, as long as the patient have the symptom, if they present TIA or cerebral infarction, I think the patient is indicated for revascularization surgery. So I think the symptom and if the CBF is lowered, I think it is indicated for revascularization surgery. So the diagnosis, which is Moya disease or not Moya disease, is not important. I think my opinion, the symptoms and the CBF is most important.
Yeah, because in my experience, I have lost my patient for one case because he just 60 years old. He presented with like a recurrent TAA, and after that I performed STA-MCA bypass and EMS. But the STA is very like very hard because it's consists of the atherosclerotic change of the STA. But finally, I can anastomosis for two anatomy. After that, the patient is get improved for his clinical condition. But for 3 weeks later, the patient came to us like a coma, like intracerebral bleeding massively, and he passed away. So this is that I just retrospective that in this case maybe it's not like just only intracranial stenosis, but I perform and have some perfusion injury at the later.
Yeah. So hyperperfusion or like the intracerebral hemorrhage post-operatively, it's very severe complication. But if the patient did not have the surgery, maybe he could cause severe cerebral infarction and could have severe disability. So I think your choice was good. But how about like the medical management, like the hypertension, was it controlled or like did he have any other complication was he treated medically sufficiently, or do you have any idea for that?
Yeah.
So about
yeah. Yes.
but
Thank you.
it's very difficult. I think that your case was was a very difficult case. But in my opinion, I think I would perform STA-MCA bypass for that patient.
Right. Thank you. Thank you, Professor
Yeah.
Miyake. Professor Kimura, would you like to come in? Professor Hidehito Kimura? Kimura Sensei? I hope you must be knowing, both of you must be knowing each other.
Yeah, I'm here.
Yeah, please.
Yeah.
Oh,
hello.
hi.
Hello, Professor Miyake.
Hello.
Thank you
Good,
for
good evening, good
this is
day.
my presentation. Thank you
Yeah,
so much.
thank you for your nice presentation. And
Thank you so much.
your so excellent research with us. Yeah, I read your papers. I've already read your papers, and it's so amazing research for me. So, according to your research, so we sometimes encounter in adult patient with ipsilateral cerebral occlusive disease. Yeah, in such case, so-called cerebral arteriopathy in recently. So in such patient may have some in some patient may have RNF213 hotspot variant. Maybe it's my opinion. Do you have some examination for the patient?
I'm sorry, ipsilateral?
Ipsilateral in the adult patient with ipsilateral hemilateral unilateral is occlusive disease. So it's not diagnosed as a Moya disease. But according to your research, the patient may have RNF213 hotspot variant.
Yes. Yeah. I think so. So in our research, about 60% of the unilateral, so-called unilateral myeloma patient had a variant. So if it's not diagnosis as myeloma disease because it's unilateral, even it could be myeloma disease, but just it is a problem about the diagnosis criteria. So Japanese the committee, how to say, myeloma disease committees are trying to change the diagnosis criteria. And I don't know. Yes. Maybe it is based on our research, but I think so. In the unilateral case, it could be myeloma disease. That is my opinion.
Thank you. So I have one question. So in my cases with myeloma patient, I always perform double barrel or sometimes triple barrel bypass with as large possible craniotomy to increase the, as much as possible. So how do you about this surgical strategy?
So I actually do not have the experience. So in my facility, it is a single bypass. And how about, do you have any experience of the hyperperfusion or it doesn't change?
Yes, fortunately, I have no experience of hyperperfusion. Just the next day, we performed a SPECT study to all patients. So usually we have we don't have encountered the hyperperfusion syndrome. Of course, blood pressure should be controlled so well.
Okay. So do you do combined surgery, just direct, or do you perform indirect also?
Also, yes, also direct, indirect also at the same time. Yes, of course, yes. To increase as much as possible.
Okay, so my question is, how about the long-term outcome? The bypass is patent for the long period?
Yes, as you showed in this your presentation here, finally the indirect bypass much more increased, much more growing up than the direct bypass. It's a tendency. So yes,
I know. So I think the benefit of the direct bypass is like the time, the revascularization. Indirect bypass takes time, but the direct bypass is immediate.
Just after surgery. I agree with. Thank you for
so maybe it depends on the symptoms or many things, and so I'm not sure it is okay with what direct, or it should be double or triple. I'm not sure, but in your cases, single was okay.
Yeah.
Yeah, I think Professor Bean would like to be the apt person to answer. Professor Bean, what would you comment, sir?
Yeah.
Kimura, actually, I did this kind of surgery from 2004. At least I have 2 or 3 years. I only do the double barrel bypass, combined EDMS. So I compared the even some triple bypass. But you know, for female patient, it's normally it's okay.
Yeah.
The double or triple is always okay because the STA was quite thin. But for the male patients, if the STA is quite large, the diameter is bigger than 1.2 millimeter, it's very dangerous because I have a triple bypass only for 4 patients, and 3 of them are good, but 1 patient suffered hemorrhage to the temporal lobe. It's not the stoma, but it's a deep hemorrhage at the same location of his last hemorrhage location. So after that, I stopped the triple bypass, and now I only do normally I only do the single bypass.
Yeah,
but sometimes if the recipient artery, the network of MCA network is quite good, I still do double bypass. And for especially for female patients, double bypass is safe. But for male patient, now I only do single bypass. And it depends on the recipient MCA network. If it's quite integrated, no problem. But if it's a late stage of Suzuki 5 or 6 stage, the MCA network was quite poor. So the double or triple bypass is very dangerous.
Yeah, thank you for your comment. I'll take care of it. Yeah.
Thank you for that very informative comment, Professor Bean. My good friend Jayanand Sudhir is here. He's one of the doctors who's dealing with Moya disease. Professor Jayanand Sudhir, would you like to comment?
Oh, well, thanks, Dr. Raja. And
welcome.
I would like to make a personal comment on the hyperperfusion and double barrel bypass for Moya. Okay. In my personal experience of around 70 bypasses for Moya, I had this hyperperfusion in just one case. And I particularly noticed that when I did this double barrel, I put the anastomosis, the 2 anastomoses were very close to each other, probably to the same gyrus. And that is when the hyperperfusion occurred in that single case. So I have a feeling whether the barrels of the 2 STAs were very close to each other, perfusing the same gyrus that resulted in the hyperperfusion in that instance. And I would also like to make a comment on the need for a second surgery following bypass surgeries or EDAMs for Moya. We also had one experience of having to operate on a subdural hematoma in the immediate post-op period after doing a STA-MCA bypass. And we did with a burhole evacuation. No other experience of a second surgery following for any other indication following Moya. But one case we had to reinforce because the patient continued to have ischemic events related to the same hemisphere after bypass. And so I had to reinforce it with an occipital artery bypass, and that helped the patient by relieving the ischemic symptoms further.
Yeah, thank you, Dr. Jayanand, for this expert comment.
Yes, you mentioned a good point that the 2 stoma not very close, shouldn't be very close to the same gyrus. So normally, if I do the double barrel bypass, one stoma located in the MCA superior trunk territory, one in the inferior trunk territory. So one in frontal, one in temporal. Yeah, not in the same gyrus.
Thank you. That was very interesting comment. Dr. Divya is here. She is the president of the women's team of ACNS. Dr. Divya, would you like to come in? Dr. Divya, are you here? Maybe she is not here. Satish Kannan is here, my good friend Satish. Satish, are you here? Maybe Binoy, are you here? Dr. Binoy? Maybe everyone is not interacting.
You're trying, that's great.
Yeah, Dr. Dubovai, Professor Dubovai is from vascular surgeon from Novosibirsk, Serbia. He's one of the speakers who is lined up for next month. Professor Dubovai, can you hear us, Professor Dubovai? Andre Dubovai? Well, I think there is one interesting comment from Dr. Sandeep that how do we avoid ischemic complications intraoperatively? That is a question. How is there any specific technique for that to avoid intraoperative ischemia?
Yeah.
I saw Professor Bin do not use a rubber dam below the donor vessel just to prevent not to sever the connections between the donor vessel and the deep gyri. So I saw, do you use the same rubber dam technique or without any rubber dam? As Professor Bin does not use any rubber dam beneath the donor vessel. What is your technique? Do you comply?
So to me?
Yeah.
Okay. So I use rubber dam. So I think Professor Bean doesn't use rubber dam. I think you don't cut the prior arteries in the recipient. I think
that is a good method to prevent ischemia. What do you say, Professor Bean?
I think he may have
I beg your pardon because I'm translating the question.
Yeah. We were talking about how you avoid using a rubber dam beneath the donor side.
Yeah. I never use that.
You never use that.
I only use a curve because my clip is different with the Yawaki.
Right.
I use
I know.
curved, curved temporal clips, so it can close the recipient artery and the small branch at the same time. You can try that. And
I would like to. I would like to. We couldn't get that.
As
a comment. Yes, please, Dr. Jayanan, you can also.
Yeah, this question is regarding the question was in relation to blood pressure management, ischemic complications. The placement of a rubber background to the recipient behind the recipient vessel actually interrupts only very small vessels. So the ischemia developing there is minimal. But the question is very real in the sense that the anesthetic has to be quite clear procedure. They have to maintain the perfusion pressure high throughout the surgery. In one case, in my early part of the career in Moya, I lost a patient because the patient's BP was not controlled during surgery. Precipitous falls of BP occurred, and this caused the entire ischemic, the entire ICA territory to go into a massive infarct during surgery. So that complication can be avoided by keeping the anesthetist in tune and keeping the perfusion pressure raised throughout the procedure, hydration of the patient well during and after the. I think that's the way we reduce ischemic complications perioperatively.
Okay.
Yeah, thank you, Professor.
To your opinion, how high should be the blood pressure maintained? What's your opinion?
That depends on the age. And I asked for a recording of the systolic and diastolic blood pressure, at least 3 recordings on the day prior to the surgery. So I know what will be the ambient BP of this particular patient. Okay. And so during the next day, during the surgery, I asked the anesthetist to maintain it around systolic BP around 10 to 20 millimeters above the systolic BP all through the surgery.
Above
systolic, yeah, above systolic, 10 to 20 millimeters above systolic.
Thank you, everybody. That was a very interesting discussion. And I'm so glad everyone interacted so much. Thank you, Professor Bain. Thank you, Professor Satoru Miyake, for this excellent presentation on behalf of the ACNS Education Committee as well as the President, Professor Yoko Kaito. I sincerely thank you for coming here, both Professor Miyake and Professor Bain. Next, today, we have on Wednesday, we have a very interesting lecture from Professor Yamamoto from Shirai General Hospital about basics of epilepsy surgery. So until then, we would like to say bye-bye to all of you. Thank you for coming. Thank you, John, for this televising this.
You're welcome.
Thank you, everybody.
Thank you. Thank you.
So,
Thank you.
Bye-bye
care.
until
Bye-bye.
next Wednesday.
Thank you,
See all.
everyone.
Bye.
Thank you,
Bye.
Professor.
Okay,
Thank
very
you.
good. Don't go away yet. I got some stuff I want to show you. There's a couple of conferences coming up. One today. Can you guys see that? Hold on. Let me. Hold on. Let me. I got to learn how to screen share. Where we at here? Okay. Just get me. Okay. This is the proper way to screen share. Okay, an Iraq grand rounds in a couple of hours. I believe it's 2 o'clock, and let's see, it's in about 4 hours. Anterior basal meningioma, do different approaches make a difference? Okay, and tomorrow there's a conference by Michael Segru. He's a big minimally invasive glioma neurosurgeon from Oklahoma, but he's now in Australia. He's giving a lecture on connectomes. This is in Chinese. It'll be in Chinese, but it's also in English. So stop by, everyone.
Sure.
Hi, Miyawaki. Today there's around 1,000 audience in the WeChat channel.
Okay.
Oh, great.
That's good.
Great.
That's good.
Thanks a lot,
Right.
Dr. Ben. Thank you very much.
Yeah.
Thank you.
Bye-bye.
It was great.
Okay,
Thank you.
bye-bye.
Bye-bye. Bye-bye,
Everyone,
Thanks so
thank
much.
you. We'll see you Wednesday.
Bye.